Thanks for joining us. What is funny about this is that, at least to my knowledge, this is the first time we've ever done a public kind of talking about this survey, even though the Employee Benefit Research Institute and Greenwald Research has been doing it for 16 years now. So it's exciting to actually do this in person and be able to talk to you and have a conversation about it. And we definitely want your feedback and thoughts. It makes us all stronger and more educated. So I'll let Paul do his own introduction when we get to his section. We're excited to have him here today. But I'll give a little background first about the study and give some highlights of the findings regarding COVID and its impact on consumer behavior and perceptions. First, about the study. One of its key functions is really to establish the incidence of different health plan types in the US among privately insured adults. And so we track 3 different health plan types: traditional, which is not a high deductible plan, and then 2 other types of high deductible plans, consumer directed health plans, which are going to be those eligible for an HSA, and high deductible plans that are not eligible for HSAs. Besides tracking incidence of these different plan types, we track a lot of other metrics and things related to health plan choice, decision-making, use of different health plans, accounts, account use and knowledge. All of those things happen during our 15 to 20 minute survey each year, and we're able to get really interesting insights across the board. We also cover some modules that come in and out. A couple of those modules that showed up this year in the survey were telemedicine. Last time we did it was in 2017, so we got a refresher on that. We also did a module on COVID and some others that always kind of come in and out of the survey. This was fielded towards the end of the summer. So we were 4 to 5 months into the COVID crisis. And so the sentiment really that we're seeing here and the responses were at that point in time. Like I said, I'll jump into some findings about COVID in general and its impact on some of our metrics. And then I'll let Paul jump in and do his intro just to keep things moving. So we can go to the next slide. Quincy. Here, one of the metrics that keeps coming up in discussion during this COVID crisis is really health-seeking behavior and how that has changed as all of us have been quarantining and staying at home and avoiding contact with others. Our survey at the end of the summer did show that 1 in 5 people had delayed medical care as a result of COVID. Again, we're talking about among privately insured adults in the US. And we saw that of those that had been delaying some sort of care or not actually deciding what to do with it, 20%, 19% of them said they would not actually be rescheduling it. That brings up a lot of questions about what that care was and how important it was for them to be getting in the first place. It brings up some questions about the healthcare system and waste and use of it. So I think those are all topics that we'd love to hear from you about, kind of what you're seeing in your own companies, among your own members, and your thoughts in terms of what this statistic is really telling us in terms of the number of people who are delaying care or just not doing it at all. We also saw that retail clinic use was down. And we know that, across the board, this delay in care or just not seeking care at all is actually having a very big impact on certain aspects of the health industry. It's actually reduced income at, hospitals. It's caused certain physician practices to close. We've also seen it have kind of the opposite impact on some other aspects of healthcare, such as telemedicine. So we'll get to that in a couple of minutes, but I just wanted to bring that up. Ironically, perhaps, although consumers are seeking less care, they are more satisfied with their health plans and their health care. This sticks out because it really seems like insurance is kind of doing its job in a sense, giving people a sense of security, that they have a plan that will back them up if they need it. What you see on the right-hand side of this screen is kind of a dig into what that satisfaction meant. When we looked at, the overall saying that satisfaction has been increasing, we said in what? right? Is it in how people are choosing their health plan? Do they feel more satisfied that they are getting the right plan for them, that they're getting the support that they need, that it's easy to select a plan? And that's not really where we're seeing that increase in satisfaction. What we're seeing is more in the use of the plan. So people feel like they have, they're more satisfied in terms of their choice of doctors, their ease of getting an appointment, some of the cost sharing that happens, feeling like their out-of-pocket costs for prescriptions or just for the visit are fair. These are all metrics that have to do with use of the plan in a time when we know that people are using their plans less. So it's an interesting thought that it's kind of this COVID bump that satisfaction increases despite use decreasing. On the left-hand side of the screen, something I wanted to call to your attention and just kind of mention about the survey is that we do track all of these metrics by plan type. And so one of those things that's been coming up, since the inception of the survey is really the difference in satisfaction between a traditional plan holder, so someone without a high deductible, versus somebody with a high deductible, be it CDH or HDH, or so access to a health savings account or no access to a health savings account. Traditional plan holders, enrollees are always more satisfied, kind of across the board on everything. And this is an interesting metric that we've been tracking over time. It really does seem to play into a lot of the other elements of value of plan selection, account selection, and use. We can move to the next slide. I did mention telemedicine earlier. So while we talk about 20% of privately insured Americans delaying their care because of COVID, we're actually seeing the opposite happening in telemedicine. There's actually been a 20% increase in the number of adults in the US who have had at least one telemedicine appointment this year. And that's a 20% increase since the last time we asked this in 2017. So we are seeing that telemedicine is being used more. We know there's an increase in satisfaction with it. There's a 7% increase in satisfaction versus 2017. We know that roughly half of those who sought out care for COVID using telemedicine were using telemedicine for the first time. We also know that people who are using telemedicine today are more than half of them are likely to say that they will use it again after the pandemic ends. So there is a lot of movement around telemedicine. There's no denying that. But what's interesting is really how it's shaking out across the population. It doesn't seem to be equally valuable or equally important to everybody. In fact, when we ask about importance, that remained steady. Just importance of telemedicine as a solution remains steady across the population since 2017. But what we're seeing is there's certain groups that it seems to matter more to. So it became extremely important to more females, more whites, more Asians and Hispanics than it did in 2017. We also see that there's a big increase, a 17% increase in the number of users of telemedicine who are seeing their own doctor. So back in 2017, we had 50% of people who had used telemedicine were seeing their own doctor. That's up to 67% now. So it seems to be people who have a doctor and that doctor is able to provide that service via telemedicine. It's making a difference to those folks as well, and to these specific subgroups within the population. But it's not a blanket increase of extreme importance to people. One other point I wanted to make on this slide before turning over to Paul is that adults in suburban and urban settings are more likely to say it's extremely important to them than adults who are living in rural settings. Again, with telemedicine being touted as kind of a solution, especially for areas where people don't have as much access to care, it doesn't seem to be shaking out that way in terms of their perception of its importance. Very last thing here, last slide, since I need to move to Paul, is the statistic that 55% of Americans are willing to take a COVID vaccine. This was back in late summer. That number's edged up a bit over time. What was most interesting to us is who is most interested in taking the vaccine, because if we want to get to herd immunity, we need as many people as possible, 75 to 85% of the population to take it. And so those people who are most willing have a higher education level, they live in urban and suburban settings, they are proactive healthcare consumers, they're checking costs and checking sites of care, and they find telemedicine services to be extremely or very important. So if you can target the vaccine to these people, you can roll it out probably a bit faster. I know I went through that fast. So Paul.
Great, thanks. And I'm going to go through my slides fast as well. But first, let me thank Edna and Quincy and Greenwald Research for including me today. One reason is I love coffee. Any excuse to have coffee is a good excuse to have it. It's one of my 5 favorite foods. And Edna and I had a good laugh when I sent her a YouTube link to an old Saturday Night Live skit known as Coffee Talk. Can't see though, most of you, so I don't know how many of you are old enough to remember the skit. I suggest you rewatch them and think about Edna and I in the roles that you see on Coffee Talk, and I'll just leave it at that. I'd much rather talk about coffee and Coffee Talk, but unfortunately we have to talk about high deductibles, which, perhaps one of the most exciting things we get to talk about these days in healthcare. We found that about 1/3 of people with private health insurance were in a high deductible plan. A little more than 1/2 of them had a HSA or HRA or were HSA eligible, and we're defining HSA eligible as having a deductible large enough to meet the HSA eligible thresholds. We don't really ask about maximum out of pocket. I don't know that people would know that. A little less than half just had the high deductible. They didn't have an account and they were not eligible one. It seems like a subtle difference, but it isn't. I would argue that the high deductible alone is a blunt instrument to control costs and doesn't do so very well, while the account potentially introduces a savings mentality. The movement of high deductibles is perhaps the strongest sustained trend in health benefits that we've seen in the last 2 decades. I do expect it to increase, but it might be slowing down. After all these years, something is holding back employers from going all in on high deductibles, and we don't understand that well. On the next slide, we've got some data on choice of health plan. About 1/3 of privately insured individuals are offered a choice of plans, but they don't have a lot of choice. What is a lot of choice? Well, eBree, we're a small business. We're located in DC, which means we are required to offer our health benefits through the Small Business Exchange. As a result, me and the people at eBree offer a choice of 60 health plans, which is a lot. And even for me, who understands all this, it could get complicated. It could get confusing. Fortunately, I'm in a position where I know what the right questions to ask are when I see something that doesn't make sense. I think a lot of people aren't. I find it interesting that high deductible health plan enrollees are more likely to report a choice of plans. I'm not surprised that they choose the high deductible. Most people will be better off in a high deductible. Think about the 80-20 rule, the fact that 20% of the population use 80% of the healthcare. The flip side of that is 80% of the population only use 20% of the healthcare, and which means most of those people are going to be well off in a high deductible health plan. When it comes to health plan value, on the next slide, this is one of my favorite slides. It doesn't matter if you're in a high deductible or a traditional plan, the same aspects of a health plan are valued equally with one difference. That is, traditional plan enrollees value low out-of-pocket costs over lower premiums, and high deductible enrollees value lower premiums over low out-of-pocket costs. It's as simple as that. That's how they sort themselves when they have a choice of plans. Going on to the next slide to talk about use of health savings accounts. Most people with a health savings account say they use it for current out-of-pocket expenses. Minorities report the other ways they use it, whether it's saving for healthcare and retirement or minimizing taxes. Note that only 15% say they're using the HSA to invest. And I find this important to point out. One, it's a small number, but it's higher than it really is. I don't know if you're familiar with some of the work we do at eBree. One of my projects is to look at HSAs, and I've got a database of over 10 million HSAs, and I could see in each of these HSAs whether or not people are actually investing. It's based upon administrative data. I know how much of their account is being invested, and that 15% that say they're using the account to invest is higher than what we see when we look at actual data on behavior. We find that about 6% of people with an HSA are investing their account balance in something other than cash. Right? Cash is an investment, but we don't really think of it like that. And only about 6% are doing something other than cash or in addition to the cash. When it comes to investing tools or tools that would get people to be more likely to invest, on the next slide, we asked people with HSAs what they need to start investing. And nothing really stands out. You got a lot going on here, but I think if we change the scale of the slide to 0 to 100 instead of 0 to 45, you'd see that more clearly. The highest percentage was 39%. And the thing we don't ask, and Ed, I don't know if there's an easy way to ask this, is maybe we could figure out a way to ask something like, once I figure out I'm part of the 80% of the population that only uses 20% of the healthcare, I'll start investing. And I think, people go into the HSA thinking that I'm going to use a lot of healthcare, I need to preserve the money and not invest it. And they don't figure out for a year or 2 or 3 that they're going to build up an account balance as long as money's going in because they don't use a lot of healthcare. And you do see that in the HSA data that I have in the 10 million accounts. You do find that the longer someone's been in an HSA, the more likely they are to invest. And I think the next slide is my last slide. This is another one of my favorite slides. The takeaway is that high deductible health plan enrollees report that they are more likely than traditional plan enrollees to make cost-conscious decisions. I'm not going to go through each of the ones we asked about, but I would note that this has been a consistent picture since we started asking these questions back in 2005. The statistical significance of the difference between high deductible enrollees and traditional plan enrollees varies from year to year. Sometimes they're all statistically significantly different. Sometimes just a few of the questions are statistically different, but it's been a very consistent picture throughout the history of this survey. So let me thank all of you for being here and taking an interest in the work that Edna and I do, and I think we are happy to answer any questions that you might have.
If there's nothing, I guess I can pop in with a question here. So Edna and Paul, when you hear that 1 in 5 people have postponed or canceled a procedure because of the crisis and 20% of them will not reschedule it, do you think that this care was unnecessary to begin with, or are people just avoiding the needed care?
I can let Paul chime in on his thoughts there. I think this is something that would be very interesting to dig into. I would imagine a lot of health plans are looking into what care was sold if they can get into that information. But it does seem to beg the question: what were they doing that they no longer need done? And we talk a lot about healthcare waste and kind of unnecessary procedures and things being done. It makes you think: is this batch, if we could really nail down what that batch of care is, if it's not that necessary, do we need to be spending on it, or is there a different way we could identify those and spend differently?
Yeah, I don't see how it isn't a combination of both necessary and unnecessary care, and it really is a small number. If it's 1 in 5 people and 20% of them that will not reschedule it, it's a small percentage, right, of people who are not getting something that they would have otherwise planned to. It's great if we eliminated some of the unnecessary care, but I'm concerned about people with chronic conditions who, while they may be overtreated, were more likely to be undertreated during the pandemic. We don't know the extent to which they didn't get medications filled because they were afraid to go to the pharmacy. Right? We don't want people with diabetes not getting their medications. We don't want people with high blood pressure not getting their medications. We don't know how many people didn't get cancer screenings. We don't know how many people with diabetes didn't get eye exams. These are things we need to look at as we get the data to do so. I think it's really important to better understand whether this is temporary or permanent and what impact it may have had on healthcare or health status.
Paul, I'm interested if you could share a little bit more about the HSA findings you've had. I know you've run a couple other studies about it, and it'd be interesting to hear how some of that lines up with what we have in this study in terms of savings and use.
Yeah, well, I think I made the comment that high deductibles alone are a blunt instrument and maybe not a very good blunt instrument at controlling costs. And the reason why I say that is it gets back to this 80-20 rule. It doesn't address the high users of healthcare, and that's where the spending is. So, once people reach their deductible, they spend even more. We released a study in October, which found that use of services that people don't need or shouldn't be getting because they're considered low value goes up when people reach their deductible. No surprise, right? Because cost sharing goes back to either first dollar coverage or something close to it. And even, the role of the account is questionable. And I made the comment that the account may introduce a savings mentality, and there shouldn't, the difference between an HSA and or a high deductible with an HSA is a lot different, or could be a lot different than a high deductible without an HSA. One of the things that I've been curious about for many, many years was what role the account plays. We know what deductibles do, but for a long time we didn't know what accounts did. And we were, for instance, my question is, as people build up account balances, and they will, even though they don't know it, as long as money's going in, because most people are healthy, don't use a lot of health care, at some point, does that account counteract the effect of the deductible? And about 2 years ago, we were finally in a position where we could look at that, and we found that in fact it does. Once people reach, have enough money in their account to cover their deductible, they use more health care. And it raises questions of what do we have to do to counteract that? And especially in a choice environment, one of the things that I'm interested in is seeing deductibles go up over time. Which we haven't in HSA plans. Deductibles in the HSA plans have been stagnant for the most part, whereas deductibles in non-HSA plans and regular PPOs is where you see them going up. So, I put it like this: if you offer somebody an HSA plan with a $2,000 deductible and they choose it, and for the first time they have no money in their HSA, eventually they'll build up $2,000. At that point, should you be offering people a $4,000 option, right? You started out with a $2,000 gap, so to speak, and a couple of years later, maybe recreate that gap. And that may counteract the effect of people using the account to use healthcare that they don't need.
Should let others jump in. Although it does make me, it kind of brings me back to the original question about low value services, value services, the ones that people are choosing to either postpone or not do at all. Do you have an understanding of the services that are then being used after they've hit their deductible? How much of that are maybe the services that they've been needing over a period of time and been postponing until they hit a deductible? Like maybe they just waited 2 years until they knew they were going to hit a deductible 1 year and then decided to use those services?
Yeah, I'm sure, in all these meetings we have, people talk about that happening all the time. They give examples of themselves behaving that way. I'm guilty of that, but I don't think we have a good sense.
That would be interesting.
So just a question for me then. So is the issue that people aren't doing what they should be doing because they're building up this balance in the account, and then it's like, well, maybe I shouldn't go to the doctor because then I'll have to spend this money?
Well, it's the opposite. Because people have built up an account balance, they may be going to the doctor when they really don't have to, because there's money in the account to pay for it.
Okay.
And instead, if we raise deductibles, or if we somehow did more education around the value of investing that money, saving it for healthcare expenses and retirement, people may be less likely to spend it on things they don't need today.
What's interesting, sorry. Were you going to say something else, Sharon?
Oh, no.
Okay. No, I was just thinking, in conversations I've had with not retirees, but people who were saving their money in their HSA and even thinking about it for retirement, they didn't want to invest it because at least some portion of them didn't want to invest it because they felt like it was an unknown that they couldn't account for. So if it was invested, it'd be locked up and then something terrible could happen and they wouldn't be able to use it. So there's this almost sense of, once it's once it's been invested, I can't take it out again. Like a penalty, like a 401k penalty, So I think there's some misunderstanding in education on that as well.
Well, yeah, I agree. Yeah, I agree. There's misunderstanding about what it means to lock it up. It's not locked up if it's invested. The only risk is that the value of your investment is lower than when you made the investment. You could sell that at any time and get access to the money. And the fact is, if you're doing it in an HSA, you're not even paying taxes on any capital appreciation if it's used for healthcare. So I think, education would be helpful there so people understand what it means to invest it and how easy it might be to get that money. Chances are, if they've got a large balance, they're not going to need all of it at once. Right? If they have a $2,000 deductible and $6,000 in their accounts invested, what's the most they're really going to need at once? $2,000. So, I think there's a lot of messaging that can happen around that. And while I said that, you do find over time, the longer someone's had an account, the more likely they are to invest. Those numbers aren't high either. Right? So people who have had an account for 10 years, only about 10% of them are investing. It's not much higher than the average.
Yeah, to your point, I think there's a lot of, just either misunderstanding or lack of communication around how that part works and what people can do with it. So,
well, especially since it is often kind of referred to as the medical version of a 401k. I think people assume that a lot of the structure of a 401k applies to the structure of an HSA, and it's a different type of account completely. So it is interesting.
And people don't understand the flexibility that you get with this account. And I'll use myself as an example, even though I'm not the average person with an HSA. I'm maxing out my contributions and it's all invested. And despite the fact that my family, we recharge deductible every year. Luckily we're in a position where we don't have to touch the HSA. But what that means is I keep all my receipts or keep all my, I track all my healthcare, and I could reimburse myself 20 years from now for the healthcare that I use this year. But I've got that flexibility as well. And again, I'm not that I'm unique, but I'm not the average person. But I think getting people more information on how this really works might be helpful.
Even the
can't hurt.
Even the slide you showed about just general education and that being and something that would make people more willing to invest and actually save more. It seems like education that's already out there, right? Access about your balance, access about just, online access to information. So it does seem like there's a miss, right? I know that information's out there. Why is it not being understood?
Yeah, there's some new HSA providers out there that are trying to do things different. And they're small at this point, but I think it's going to be interesting to see what their experience has been, or what their, the people with HSAs with them, if they're any different than those HSA providers that are, hate to use the word legacy with HSAs, but that's basically what they are, the ones that have been around since close to the beginning.